All right, guys, so we're making our way towards the second part of wound healing here. And some of the resources we've been using so far are Peterson's Principles of Oral and Maxillofacial Surgery, First Aid for the USMLE Step 1, and OpenStack's Anatomy and Physiology. So we're going to talk a little bit about nerve healing in this section. So when we think about nerve healing, we need to also think about nerve damage. So damage occurs on a spectrum, right? We have simple things as small as a contusion, and then we have absolute, when we sever something, like severing a nerve, severing an artery. When we think about the entire spectrum, there's obviously some things that are more mild and more severe. So similarly, there are different responses from the body. So when it comes to nerves, we have neuropraxia on the mild side. On the moderate side, we have axonotmesis. And on the severe side, we have neurotmesis. And I thought this diagram did a really good job showing us each of those. And an important thing to notice here is these arrows show us the endoneurium, the perineurium, and the epineurium. And those three layers are actually going to be crucial when we start talking about the potential for regeneration in different situations. So, first up is neuropraxia. Neuropraxia, we can almost think of it as a contusion of the nerve. And when we think about it, we should be thinking of a transient interruption of conduction, okay? And what causes something like this? We usually think of blunt trauma or traction, inflammation, or local ischemia. Those are the general things that we think of as causing the contusion of neuropraxia. The contusion that eventually ends up getting healed, by neuropraxia. But the biggest thing is that this is some sort of interruption where we have a transient interruption of just conduction. So what you can see here is there's no discontinuity of the axon or the epineural sheath. So there is absolutely no discontinuity, and that is what makes neuropraxia. Generally, you have full recovery within a few weeks, and an example of this would be radial nerve compression, which is also known as wrist drop. Next level up, we have axonotmesis. So axonotmesis is the physical disruption of one or more axons with no disruption to the surrounding sheath. So when we look at that image down there, you can kind of see how that yellow line in the center, that's the axon. So we have the damage that corresponds to the number and type of axons that are damaged. So there's no damage to the Schwann cells or the surrounding stroma, but there is disruption of the actual axon. So there are a couple of different potential outcomes here. We can have functional recovery, and it depends on the extent of the damage, but we can also have axoplasmic degeneration. So when we think about causes of axonotmesis, we're thinking of severe blunt trauma, we're thinking of nerve crushing or extreme traction. Some examples of this would be maybe in a displaced bone or a crash injury. And so like we said, outcomes, we can have axoplasmic degeneration, which occurs distal to the site of injury and just barely proximal to the site of injury. So we're thinking about 2 or 3 nodes of Ranvier backwards or proximally. So generally, when we think about the potential for recovery from axonotmesis, we're thinking of how much involvement there is of the Schwann cells, right? So if we just have some endoneurium involvement, then we're thinking about there is some potential for regrowth. But when you think about perineurium involvement, there's minimal potential for regrowth. Now, when the epineurium is also involved, there's almost no potential for regrowth. So next up, we have neurotmesis, and I would say this is the most severe of the three. So it is indeed the most severe form of injury. We have complete transection of the axon and its surrounding sheath or stroma. We generally do not have spontaneous recovery. That's usually pretty rare, which means that we have a pretty poor prognosis. And the Schwann cells begin to undergo Wallerian degeneration. So a little bit about Wallerian degeneration. Usually, following neurotmesis, we have Schwann cells begin to take part in Wallerian degeneration, and macrophages begin to migrate inwards. So this usually happens within 78 hours, and all distal axons are usually affected, and the proximal neurons are typically affected just 2 to 3 nodes proximal to the site of damage. And like I said, we start to see macrophages returning to this site, to this zone of injury, and they're migrating there. So Wallerian degeneration kind of occurs in these 3 different pieces. So we have Schwann cells and macrophages helping clear all the axonal debris. But then we also have the Schwann cells proliferating. And we essentially, so the proximal Schwann cells, they attempt to reach the distal stump. So they're trying to reach out and grab it. And the distal Schwann cells, they're forming Bunger's band. So if the two are surgically aligned, there is potential for healing because the proximal Schwann cells that are trying to reach out, they can attempt to grab Bunger's band on the distal aspect. But if they're not realigned properly, then we have the potential for creating a neuroma, because essentially those proximal stumps are reaching out into the unorganized fibrin clot. So there's a good picture of a neuroma on the right-hand side of the screen, right over here. Okay. And so Bunger's bands are capable of accepting regenerating axonal sprouts, and the Schwann cells are also constantly secreting neurotrophic factors to facilitate cellular repair and cell-cell adhesion molecules to direct axonal growth. Okay? So nerve regeneration typically happens at a rate of about 1 millimeter every day, and it typically lasts about 3 months. And the regenerated nerve continues to thicken in diameter. And there can be a lot of variability in the rate of regeneration, but this is just a typical average of 1 millimeter a day. After 3 months, it ends when a thin myelinated axon reaches the end organ. And one of the things that I think is incredible is this is just another example almost of contact inhibition, something that we've talked about a little bit when we were talking about re-epithelialization of a wound. So that wraps up this section on nerve regeneration and nerve healing. And I just want to share these sources with you guys. So this is where I got some of these pictures, the nerve regeneration picture, of course, but also the neuron damage picture. So if you guys have any questions, please feel free to put them in the comments below, and I'd be happy to answer them. Thank you.